Good morning, and welcome to this month's edition of the Oak Hill Regional Community Development Corporation's third Wednesday Parent Resource Chat. My name is Bettina Campbell, and I am the Social Service Director, and I'm also a Medicaid CHIP assister for the Oak Hill Regional Community Development Center, which is a parent corporation for Healthy Kids, Mississippi. I will be your moderator today. Also joining us today is Lottie Miner, who serves as the project director for Oak Hill Regional Community Development Corporation, and Thomas Robinson, our technology and metrics director, who's assisting us with technology today. We recognize our board chair, Jennifer Garrett, and our executive director, Dr. Michael O. Miner. In addition to this Zoom chat, we are also restreaming today's webinar on our Oak Hill Regional Community Development Corporation and Healthy Kids Mississippi Facebook. Feel free to share your medias. Now, got that out of the way. So today, our guests are Dr. Leslie Scalaris and Reverend Dr. Sarah Bailey. And they're going to talk to us today about stroke. And so I think that they'll also share information about how a layperson can identify stroke and how successful faith-based and community programs and interventions can be. So I wanted to share just a little bit about who these wonderful ladies are. And when I say wonderful, I mean wonderful and very, very, very community dedicated. And so Dr. Leslie Scalaris is a professional of neurology and health education and behavior at the University of Michigan. Go Michigan. She is a board certified fellowship trained vascular neurologist. She has worked in partnership with the Flint community for the last 12 years. Her research focuses on health equity, community-based participatory research, and health services. She is leading 4 NIH-funded interventions in stroke preparedness, cardiovascular disease prevention, and unsuccessful aging. Excuse me, I should say successful aging. I think I was thinking about myself when I said unsuccessful. The successful aging. Dr. Scalaris sees strokes patients in the hospital and clinic there in Ann Arbor. Now the lady that I'm going to introduce you to next, we go back a long way. Reverend Dr. Sarah Bailey is the elder of the Full Gospel Baptist Church Fellowship International, and she holds a doctorate of divinity. She's been the pastor of Portraits in Christ Ministries since 2002. Dr. Sarah is the CEO and co-founder of Bridges into the Future Incorporation, which is a community-based nonprofit organization in Flint, Michigan. And it focuses on health promotion and prevention. She is the vice chair of the community-based organization Partners, and she's a current member of the faith-based subcommittee. Now, this committee is actively involved in community education on COVID-19 and vaccines and distribution, as well as operationalizing the Genesee County resolution declaring racism a public health threat, or public health crisis. She is currently assisting the Community Engagement Corps of Mission in developing an academic protocol for junior researchers in the community and community members to participate in prior to being sanctioned to conduct research in the community. Additionally, and most importantly, she says she loves God. She's a mother of 3 natural sons and 1 daughter, and has foster cared more than 10 children. She has 10 grandchildren and 6 great grandchildren. What a busy, busy lady she is. And so today we are so excited to hear what you have to say. I know personally what a wonderful program it is, and I'm so just ecstatic to be able to share this information with our parents in Mississippi and across the nation. So again, welcome, and ladies, it's on you.
Oh, thank you so much. I feel so welcome. Thank you for such a great introduction. We just want to let everyone know we're really open to questions or anything, we're here for you for the next hour. So you can put questions in the chat, or we specifically left time at the end for a dialogue. So without further ado, I'm going to pull up our slides. Okay. We're going to start speaking about everything you need to know to prevent stroke and get a stroke treated from an academic and community partnership. Reverend Elder Bailey and I will co-present, as is traditional in community engaged research. So Elder Bailey will start. Oh, sorry, these are our disclosures. We have NIH funding.
Well, good morning, everyone. And I know it's afternoon here, but it's morning there. So good morning to you all. Our premise today is to achieve health equity and work at the intersection of the community and the health system. And we know this is very much needed. Dr. Scaleras and I have worked together for the last 13 years, and we see that there is a place where community and the health system can intersect. Next slide, please. Community engagement research. In the past, research has been directed, and the community has rarely benefited, especially our community has rarely benefited from all of the research efforts. Just taking Tuskegee into mind, communities most impacted by health disparities are likely to be less involved in the research process. And this is often due to the lack of trust, experiences of racism within the medical field, distrust and reluctance to participate in research among communities often who need it the most. Next slide, please. There is a continuum of community research, and it starts out on the traditional end, and it moves more towards community-based participatory research. Now, there is a difference, because there can be community-based research that's placed in the community, but there's limited involvement from the community. It's just research that's done on us and not with us. And that's the difference. Community engaged research is research that is done with the community, and community and academic partners share expertise, decision-making, power, and project responsibilities. They recognize the unique strengths that each of us bring to the research process. Next slide, please. Our partnership started in the fall of 2009. It's a long story, and we just don't have time to get into it here. but this is Leslie and I as we are starting. As you can see, I'm a little bit younger.
I'm
Leslie's
very
still
young.
young.
Oh,
She's
no.
still young. Next slide, please. The Community Advisory Board, the goal there is to promote health equity through actionable research in the city of Flint and in the state of Michigan. And you can see our diverse Community Advisory Board. And it's comprised of stakeholders from more than 30 organizations and individuals. Next slide, please. The community partner ecosystem, which intersects the hospitals, church-based organizations, support groups, pharmacy, the farmers market, barbershops and beauty salons, senior citizens, the soup kitchen, the Chamber of Commerce, neighborhood advocacy, community centers such as the YMCA, civic organizations, public libraries, schools, extensions. In other words, in order for the research to actually be utilized and broadly diverse, it has to reach all sectors of the community. And there is a whole system that needs to be in place in order for the research and the interventions that are developed to actually have any type of impact. Next slide, please. Academic and community partnerships. The universities are valuable thought partners for community organizations. Community organizations often have limited resources, and Lord, do we know our resources are often limited due to, and there is much work to do. With limited time, money, staff, is often to think beyond the day-to-day issues facing community organizations. And I'm sure some of you have experienced that. Partners on research projects helps community organizations to take measure, risk, and think outside of the box. The community benefits by gaining access to the university benefits by gaining access to community members through trusted partner organizations and have the ability to learn how to adapt to meet the people's needs in order for the interventions to be successful and sustainable. And there is access to experts on both ends, because the community needs to understand you are an expert in what you know. No one can beat you knowing your community, and the academics are experts in their field of study. Next slide, please. Here we see that our program, which we called it, we had so many names for it, but we started out with Stroke Ready, Reach Out, My BP, My Life, and now we're into Unite. Starts out with the community, engaging the community, our advisory board, tech companies, health system partners, and local and state policymakers. We also test the effectiveness of our stroke education program. We tested the effectiveness of behavioral interventions on lowering blood pressure, tested the effectiveness of behavioral wearable instruments, such as, watches and other technological things that, hey, I'm from the old school. We just looked at a clock. We didn't always wear it on us or hold it in our hands. And then also with Unite, which is a health project that evaluates the health impact of co-locating a clinic in an older adult affordable housing complex so that they can have access to medical care right there on the premises where they live. We also do a training program, which is My BP Life students and the interns from the University of Michigan, undergrads, medical schools, School of Public Health, and residential fellows. We also do Healthy Flint Research Coordinating Center, which is to actually coordinate a lot of the research that comes into the city of Flint. Because we found out during the water crisis that more than 400 researchers descended upon us, and there had to be some kind of way to coordinate all of that, unless we would be inundated with researchers all the time, especially in the faith-based community, because that's the place where most of us gather. Next slide, please. The goal of Stroke Ready and Prepare. Stroke is a medical emergency, And you must begin to recognize the signs of a stroke in order to receive medical care as soon as possible. The clot busting drug TPA increases the chances that a stroke patient will recover, but it needs to be applied and administered within a short period of time. So it's extremely important to call 911 if you see someone having a stroke. But what I found out is that many people didn't even recognize the signs and the symptoms of a stroke. And strokes are preventable. So most important thing is to treat high blood pressure. And I know that that is a problem within our community, and some of it is based on our diet, our lifestyle, but we need to make sure that we have our blood pressure tested and treated. Next slide, please.
Should I take this?
Yes.
We'll switch off since we're talking about neurology now. Thank you, Dr. Reverend Elder Sarah Bailey. I really appreciate it. I guess I'll just take one step back and introduce Stroke Ready, just to give people some context of how long we've been doing this. So Elder Bailey and I started this about 12 years ago. We initially developed this program in partnerships with 3 Black churches in Flint, working with their community health teams. And we had a pastor who was a really strong champion of our program. And since then, we pilot tested this education materials, and then we subsequently developed a larger project where we've rolled out stroke education to 8,000 people in Flint. We're committed to building capacity in the community such that we trained 30 stroke peer educators to deliver this information that I'm going to deliver today, or that Elder Bailey was just delivering. She did such a good job. I didn't want to stop her. I felt really, she didn't really need a neurologist, but since I'm here, I will deliver this bit today. But I think I just wanted to step back and show an example of what community and academic partnerships can do. So back to the slide. So there are 2 kinds of stroke. There are hemorrhagic stroke or bleeding kinds of stroke, or ischemic strokes. So with a hemorrhagic stroke, a blood vessel bursts and blood comes out of the blood vessels and into the brain, versus an ischemic stroke where there's a blockage in the artery and blood can't get past that blockage, depicted here. And so the brain that's downstream from the clot dies. About 80%, 85% of strokes are this ischemic stroke kind, whereas about 15% are the bleeding or the hemorrhagic stroke type. Stroke is really common. Most people on this call, or most people in general, know folks who know someone who's had a stroke. I probably should have put a different football stadium on here to depict it, but this is the one I know most. So this is the U of M football stadium. It's one of the largest in the country. It holds about 100,000 people. 8 times that are the number of strokes that occur each year. It's the 5th leading cause of death, and it's the leading cause of disability. African Americans have more stroke than any group in the United States. So these are numbers showing the number of strokes per 100,000 people. And there's about 270 among African Americans compared to 150 among white people. I think the second point of this is not only are there more stroke, but the strokes occur at younger ages. So many strokes in white people are happening amongst people in their 80s. But there are many more strokes in young people, so 40s and 50s among our Black Americans. So now we're going to go through how to recognize the signs of stroke. So strokes can cause different signs, and it depends on that blockage of where in the brain the blockage is, because different parts of the brain control different things. To a neurologist, that's really cool, but to other people, I think everyone thinks it's kind of cool. So if there's a stroke that happens in your speech part, would be a different from location from the stroke that happens in the part of your brain that controls your movements, or the part of the brain that controls your coordination. So the symptoms you have depend on where the stroke is. So now we're going to go through the acronym of FAST to help. This is the classic acronym to help people remember the signs of stroke. So it's F for face drooping, A for arm weakness, S for speech difficulties, and T for time to call 911. So if you look at this person, you can see that she has a droopy face or a twisted face. If you can't tell and you think that this may be happening to you, or you witness it happening to somebody else, ask them to smile, or to move their mouth. And if one side doesn't come up as far as the other, that's a sign that that side is weak and that side's there's a stroke happening. A is for arm weakness. This is a sign that one side of the body is shutting down. In order to test this, you would ask the people to hold up their arms like this. And if one of their arms drifts down, that would be a sign that that arm is weak and that that's a sign of a stroke, and to call 911. S is for speech. And it can be for slurred speech. So oftentimes I've heard it described as people speaking as though they're drunk, or that they're mixing up speech such that they can't find words. So they will misplace the word they want to say with another word. Sometimes it's hard to tell. So ways to test it is to have them repeat phrases. So you can have them listen to what they're saying and then listen to the context of what they're saying. It's usually pretty noticeable. It's not the thing that happens to that just happened to me where I was trying to say something, I couldn't think of the word. That's very normal. It is where I would say new words, or that happens repeatedly and continuously. And then T is for time to call 911. So if you see any of these signs, it's time to call 911. We often get the question of do we need to call 911, or can we just take the person to the hospital? It's much better to call 911 because if that happens, the ambulance calls the emergency room and lets the doctors and the team know that there's a stroke patient coming in. So we as a team are ready to treat the person before they even come to the hospital. So unlike when you go to the emergency room, oftentimes you're waiting to get seen. It's just the opposite case scenario, is that the doctors are waiting for you to get there because they're all ready to go. I'm gonna show a video of stroke signs now to help us really think about them. Okay. Oh, I need to stop share because I didn't click this on. Give me 1 second to just pop out and pop back in.
Hey, Mom, we buy these cookies.
Yeah, they can be a treat for your good grades.
In that case, I should ask for a car.
You gotta wait till you get your license for all of that.
I hope we win our basketball game today.
Yeah.
What was that?
But
Mom, what's going on? Are you okay?
So you can see in this video, she has a droopy face and slurred speech that's recognizable. I think the main point in this video is to show that she doesn't have weakness per se in her arms and legs. It's just isolated to her speech. Here's another one.
Hey, Mom, we buy these box of cookies.
sure, that can be a treat for your good grades. Oh, I'm sorry.
Hey, Mom, you dropped these.
Oh,
Are you okay, Mom?
yeah. Thank goodness I got 2 arms.
So that's a good example of arm weakness. that is not so profound that she can't raise or move her arm at all. It's more subtle, a more subtle sign. And here's the last one.
Hey, Dwayne, how's it going, man?
Man, it's going good. Hey, it's almost Friday. I got the weekend off, you know. I'm thinking about going to my church function, you know, just relax a little bit, you know. So what's going on with you?
Oh, I'm off too, but I'm planning on going to the lake.
The lake, now that sounds interesting. Tell me how far is it? You know, I might just come along with you.
It's about 30 minutes from here. Hey, man, can you hand me that folder on Susan's shelf? It's a spreadsheet
Sure, no problem.
from a project we're working on.
Yeah. Hey, I was thinking, you know, if I come to the lake, you know, you want me to bring that hot barbecue sauce you like?
Yeah.
Charles, you want me to bring the hot barbecue sauce?
Man.
Are you all right? I don't understand what you're saying.
That's
So that was a video showing speech difficulties. We made, just as a endorsement of community engaged research, we made these with a Flint production company and local Flint actors. So Ms. Bettina and Elder Bailey likely know some of these folks in the starring in our videos. So the main point is that even one of these signs is enough. And if it does happen, call 911. And the reason that calling 911 is so important is that there's a clot buster drug that works better the faster that we give it. So if we think of that stroke as being a blockage in an artery, there's a medicine that we give. So here's the blood flows coming. There's the blockage and coming up. If we give this medicine depicted here in yellow, I think of it as Drano for the brain. This is your pipe, we put the Drano in, and then it cleans out the artery or removes the clot. But the earlier it's given, the less chance that brain has had to die and the better it works. We need to do that because blood is the way the oxygen flows to the brain. The brain needs blood, needs oxygen. We have about, the faster the better is the take-home message. The typical is about, we can give medicine after up to about 4.5 hours, but it takes about an hour in the hospital to give the medicine. So even if you think that someone's having a stroke, it was important to get to the hospital right away. So this is just another way of showing the chance of recovery. So if you get it really, the medicine really early, the chances of recovery are much higher than if the medicine is given later. It still works and people still benefit from it, but the benefit is less. This is just going over about the reasons why to call 911. The other thing I did not mention is that if the patient gets worse, they can help you and you're not driving a car yourself, but that there's somebody there to help if the patient gets more sick. I'm going to skip this. Well, I'll play a little bit actually. I won't play the whole thing because in the sake of time. So we created that music video, the lyrics and the musical accompaniment was written by the community, by the music director at New Jerusalem. It was performed by community musicians, filmed in the community, and bad dancing by me. But I think we played this a lot throughout the community because we think it's catchy, and music is a really important way to reach people. So now I'm going to turn the last bit of this, the talk to stroke prevention. Based on the, this was a one of our community partners requested this, and I will never forget the day we were at a community advisory board meeting, and someone raised his hand, or, spoke and said, "This is great, your little call 911 thing, but we don't want to have a stroke. So can we do some stroke prevention, or what can we do to not have a stroke?" And Sarah will know I was pretty reluctant for a long time to do stroke prevention. I thought that was the role of primary care doctors, but I was true to the principles of community engagement. This is a community requested area of need, and so we went into the stroke prevention field. So what is stroke prevention? What does that mean? It really means blood pressure. So the #1 risk factor for stroke is high blood pressure. Other risk factors are diabetes or sugar, tobacco use, obesity, physical inactivity, poor diet, and stress. But if you had to prioritize one of those, it's controlling blood pressure. So one important piece about controlling blood pressure is blood pressure self-monitoring. So basically knowing what your blood pressure is. And so we would recommend that people have home blood pressure cuffs if they have high blood pressure, and take their blood pressure in the morning and in the evening every other day for a week or two, and present those to their doctor if their blood pressure is too high. There's a thing called white coat hypertension, which means that when you go into the doctor's office, just being in the doctor's office makes people anxious and raises their blood pressure. So really home measurements are better than the measurements you get at the doctor's office a lot of time. I think there's a role for both, but I think the role for taking your blood pressure at home is underappreciated. This just says about taking your blood pressure. So what is high blood pressure? So recently it's been changed such that it's even more stringent. So high blood pressure is now defined as over 130/80. These are the newish American Heart Association blood pressure categories. So if you're less than 120/80, good on you. Your blood pressure looks great. Keep it up. If you're 120 to 129, it's sort of borderline. You should start thinking about lifestyle changes that can help control your blood pressure. So eating less salt, increasing your fruit and vegetable intake, and doing more physical activity. Over 130 to 180, now you're in that new high blood pressure category. You want to talk to your doctor within the next month or so. You want to do the things the lifestyle things of less salt, more fruit and veggies, more exercise. And you may or may not need to start or change your medicines at that point. Sort of over 140 to blood pressure of over 140 and 90, at that point, you will most certainly need to start taking medicines. And then finally, if there's a hypertensive emergency, so your blood pressure is over 180, over 120, let's call your doctor right away. You likely need to start or change your medicines. And if you have any other symptoms with that, such as chest pain or any of the F.A.S.T symptoms, face, arm, speech changes, you call 911 right away. So that's all we wanted to share with you folks today. We specifically left time for a dialogue. I know my attention span post-COVID is much less than it used to be. So to listen to people chatting or talking, so I think dialogue is better. And so I'm going to stop sharing and open it up for questions for either Elder Bailey or I.
So if you have questions, just, you can raise your hand, or you can just open up your mic and you can talk. I'm going
Yeah.
to start out. We do have, there were some questions in the chat. One wants to know, does stroke come on slowly, or does it happen all at once?
Yeah, really good question. Yeah, oh, I should have been more clear about that. So thank you for that great question. All at once, so it's sudden. It's 1 minute, you're totally fine, and the next minute you're not. It's like a light switch, abrupt like that. So things that the other ways that some folks wake up with their stroke symptoms, and then we don't know when they started. But if you're awake, it's a sudden onset of symptoms. Good question.
Does anybody else have a question? If not, I have another one. Questions? One of the things that you talked about are the two different types of strokes.
Yep.
Which one has the greatest success rate, or recovery rate, I should say?
Yeah, that's a good question. It's really tricky. So the TPA, the clot buster drugs, work only for the blockage kind. So and those have been shown to have a really huge benefit in terms of stroke recovery. That being said, after that, it gets a little nuanced, but I'm going to try to walk through it. But you can tune me out if it gets too confusing. So the bleeding kind of stroke, the hemorrhage stroke, that has the highest mortality rate. So people are more likely to die from that type of stroke than the blockage kind. That being said, if you don't die from it, recovery can be pretty good, because unlike a blockage stroke, all that brain isn't dead. So when the blood kind of resolves or goes away, oftentimes there can be more recovery because it's not just dead brain underneath there. So I think it gets tricky because the death rate is higher, but I've seen the literature's, when we look at how patients do, they actually can do quite well. And I've definitely seen it in my clinical practice. Good question. My answer wasn't super straightforward, but that's the right answer though.
Wonderful, thank you so much. There is another question in the chat. It says, are the symptoms that you mentioned the only symptoms of a stroke?
Yeah, that's a really good question. They're the majority. So if you get, you get about 90% of the symptoms if you know that FAST acronym. There are different types of strokes, but oftentimes they involve some portion of those three symptoms. So if you know those, you're doing good.
Anybody else have any questions? Now, sometimes people get confused and they think that if you take some medicine, it's going to change what happened. But the medicine that you take for a stroke, will it reverse any of the damage that has occurred?
That's right. Yeah. So that clot buster drug, that TPA, that's a great question. So that clot buster drug, what it does is that it gets that clot out of there. It removes the clot so the blood can flow to that part of the brain again. And so it doesn't restore the brain tissue, but what it does is oftentimes that brain is just stunned, like, oh, what's happening? I don't have enough blood flow. And so if we can get blood flow back to it quickly, it will come back to life. It's just stunned, not dead yet. So we want to get that blood flow back to that area.
So what I'm hearing you say is that it's very, very important that we know the FAST model, and that we understand those symptoms, and that we act immediately. Like sometimes mama might say, or daddy might say, I'll be all right, or it's a child, oh, they just stunned, they'll be okay. But if you see any of those symptoms, they don't all have to be at the same time. It can be just one symptom. And it's important that we react as fast as we can.
You got it. Yep, that's exactly right. Good summary. I think the only thing I would add to that, and I should have said, is that oftentimes, if you see somebody having it, the most helpful piece of information that the doctors in the emergency room will need is the time that it happened. So if you witness a stroke happening, just noting what time those symptoms started is going to be really important to make for the team to see if you're eligible to receive those clot buster drugs.
So then there is a time past the what did you miss, 5 hours or 4.5 hours? That past that time, the drug doesn't do you any good, or they won't administer the drug?
Yeah, good question. So I would say before 18 months ago, 2 years ago, no, they wouldn't have. Now the data, there's, one of the great things about stroke is that in the last decade, my career, the treatments have gotten a lot better. And so now there are special CAT scans that we would do to try to see if we could still give that clot buster drug, but not everybody. So what the CAT scan does is it tries to identify how much of the brain is that stunned brain and how much of that brain is dead brain. And then if it looks like there's enough stunned brain left, they would go ahead and deliver that, give you the clot buster. But because so much time has gone by, there may not be enough. So it's 4.5 hours without the need for some a special CAT scan. And then after 4.5 hours, you would need a special CAT scan that's done at the emergency room to see if you could benefit.
Okay, so we have 2 more questions. One to ask is, are African American males or females more prone to experience a stroke, and why?
Oh, that's a good question. It gets, I guess I don't. So in the, I'm trying to think of the best way to describe it. So among younger people, so less than 65 working age folks, men are slightly more likely, Black men are slightly more likely than Black women to have a stroke. That flips as people age, and some of the thought may be is that in the 80s and 90s, Black men have died of other things, and there are more Black women alive at that point to have more strokes. So and so I think that but in general, there are less sex differences in stroke than age differences. So the most striking differences in who has a stroke across the country are that Black people have more strokes at young ages. And I think that's what really drives some of Elder Bailey and I's work, is that we know that stroke is just not a disease of one person. When someone has a stroke, it really affects their whole family. And it has really kind of people make lots of life changes in families after somebody has a stroke. And those changes are more dramatic and lasting when it's a young person. So we sort of made it our life's mission to try to decrease this big age difference that such young people are having strokes. Not that we want anybody to have a stroke. We don't want anybody to, but the stroke has unlike other diseases, stroke has a big impact on families, as well as the patient themselves.
Okay, thank you. I'll have one other question. It says, will the use of aspirin prevent strokes?
Yeah, great question. So the literature's all over the place in terms of in terms of if someone without any risk factors should take aspirin. I can tell you that it's a really individualized decision about other things that are going on in your health, to know that if the risks of aspirin are less than are more than, if the benefits outweigh the risk, depending on other things that are happening in your health. I can say that if you've had a stroke, you should absolutely take an aspirin. That data is really clear and doesn't need to be so specific to one person. Like, we know that everybody after a stroke should take an aspirin unless they have atrial fibrillation. Then they should take other medicines that work better for people with atrial fibrillation. Good question.
Okay. Are there any other questions?
Hi, Sister Lieutenant, Pastor Montgomery. For geographical locations, and I know, thank God for the Michigan Wolverines and those Spartans up there, that part of the country. But here in the South, how does that vary from north to south when you talk about stroke?
Yeah, no, that's a great question. Yeah, that's a really great question. So, so there is this, there's more strokes in the South. So we call it, in the stroke doctors or the stroke scientists call it the stroke belt, which is in the sort of coming across the southern part of the United States. There are more strokes for sure than in the northern part of the country. And there's a big research study called REGARDS that's run out of University of Alabama, that has spent the last 15 years looking at why that's the case, and trying to understand why there are more strokes in the South. And it turns out to me, it looks, my interpretation of it, it's many reasons. But one of them being a higher, more people have high blood pressure. But then, that begs the question, well, why do more people have high blood pressure? And, you can kind of like keep walking it backward to try to get to the fundamental cause of why that's the case. But I can tell you that that's definitely the case.
I think, and just again, culture has a lot to do that in the South, because, I mean, don't get me wrong, barbecues is across the country, but we still have our Southern cuisine. But at the same time, I would think that in the South is towards activities that will be more active in the South than the North because of climate and those type things. So I guess a lot of the culture variance has to do with that.
Yeah, no, I think that, diet is one thing that they have found is different. I don't know. I also think that, like, I'm probably not the best person to ask about this, because I also think that, like, barbecues are joyful and that people need joy in their lives. So I don't know. I have a hard time coming down on the barbecues, I have to admit.
So I'm not going to come down on the barbecue, but I will come down on the use of salt. And what I generally instruct people, that if you shake it, don't cook with it. If you cook with it, don't shake it. In other words, what happens is that we cook with salt, and then we add salt after the food has been cooked. And you can reduce your salt intake by just deciding, I'm going to not cook with it, or I'm not going to shake it once it's been cooked. And that can help. That's one of the things that can help the reduction of salt in your intake. And I do know in the South, you can taste the salt.
I think to that, again, just the economics in and of itself, because there's more stress about, and also in some states, unfortunately, who have agreed not to sign on or extend Medicaid, or that people don't have the access to doctors and to preventable information that will help them to be able to make better decisions about what type of foods they should eat. Again, they're not an activity and the role that that plays. They're not. I just think that as Pastor Montgomery said, it's culture, but it's also economics.
Yeah, and you know,
and having and lack of access to care, to preventable care, because they don't have the insurance that
that's why your
provides.
program, that's why your program, Ms. Campbell, is so important, so very important, is to continuously educate people, and then each person that's educated to make a choice that they will try to educate one other person. You know, each one reach one has to be something that has to go throughout the community, because with the lack of resources, we can then become the resource. And that's what community participatory research and community participatory interventions are about. It's about the community helping to heal itself. And so each person that's on the line here can just say, I'm going to just reach one other person with this, and make sure that they have this information so that they can reach someone else. That will help.
Also,
Oh,
with
there's
that being said, when it comes to, I apologize for strokes, is that is what I consider the silent ticking time bomb. Because when you talk about blood pressure and cholesterol, those type of things, you don't get a big alarm other than going to your physician to get that checked. And I think that's one of the things that as people of color is that we have to do, is to make sure that we get our blood pressure checked and our cholesterol, so that we would hear this bomb that is ticking silent.
Yeah, I agree. I agree with that. And I agree with what Ms. Campbell said to you. Like, I think there are a lot of structural barriers and access to care that are really prevalent in Mississippi and in other states in the stroke belt that I'm sure I don't need to tell you folks all about. So I think that, you know, doing things that you can do and that you can do in your social network is important, but I do think that there are structural changes that need to happen as well to help everybody be as healthy as they possibly can. So I agree with that. What else? Ask us more. This is kind of really fun.
Well, here I go again. I guess this is more of a statement. My brother, back in July, had a stroke, and he stayed in hospital probably for about a month. But nevertheless, he came out, didn't have no limitation as far as memory, limbs, and those type things. And one of the things that he does a lot of walking. And according to the physician, they said the condition that it was in tremendously helped him to recover from the stroke. So I guess what I'm saying, being active, doing something for cardiovascular and those type of things, that unfortunately if a stroke happens, you have a better opportunity for recovery and rehabilitation, those type of things.
I'm sorry. There's a question. One, it says, with life expectancy increasing, and 10,000 baby boomers retiring every day until 2035, what is the projected increase of strokes especially among women since they outlive men by 3 to 5 years.
Yeah, the projection of strokes is to dramatically increase. The number one of the, after high blood pressure is the number one risk factor, modifiable, so something we can change risk factor for stroke, but age is a close second, and we can't change that. So yeah, I think that as you're suggesting, the number of strokes among our older Americans, just by sheer proportion of Americans who will be older in the next couple of decades, the stroke is projected to increase. Good question.
Okay. Well, thank you so very much. This has been so informative. And as usual, whenever I'm in conversations with you guys, I learn a lot more. And my memory is refreshed. And I think I can say the same for the people that are on the call, is that we have learned something. And those of us who had gone through any type of educational information about stroke had our memories refreshed. And now we have our job to do, as Elder Bailey said, each one teach one. So it's been awesome. And I just want to encourage everybody to seek out and help somebody else, or be willing to go with them to the doctor if they want you to go with them to the doctor. And just be a resource for your community. As you hear these different health tips that are being provided for you, please use them. So I hope that you had your pencil and paper today and you took lots of good notes. Someone asked if we were recording. I think that we are recording. And information can always be found on our webpage. So I just want to give you a reminder that on Monday, May the 23rd at 6 p.m., please join our Ask Mary and Pat Zoom webinar for more information. This is usually the last Monday of the month, but because that's the holiday, we are doing it on the 23rd. So May 23rd, mark your calendars. And finally, remember our next third Wednesday parent resource chat will be June 15th. And this workshop will focus on top men's health threats. The list includes heart disease, cancer, and unintentional injuries. Thankfully, most men's health threats are largely preventable. And our guest will be Dr. Derek Griffith, the founder of and co-director of the Georgetown Racial Justice Institute and the director of the Center for Men's Health Equity. So again, you may learn more about our information at www.oakhillregionalcdc.com or healthykidsms.org. And once again, we want to acknowledge our board chair, Jennifer Garrett, and our executive director, Dr. Michael O'Miner. This has been a production of the Oak Hill Regional Community Development Corporation, belonging, building, and bridging in the Mid-South region and across the state of Mississippi. So, Elder Bailey and Dr. Scalaras and anyone else that's on Zoom, we invite you to stay on for a few minutes as we sign off social media in case there are any additional questions or comments that you'd like to share.